is taking shape with the kicking off of registration for the Social Health Insurance Fund as the country shifts from the now repealed NHIF. Now, under UHC, all Kenyans and non-Kenyans will have access to a full range of quality health services that they need. But what does SHIF mean for you? And what differences are there? That is a conversation we're having in studio this morning with George Gibore, who is Secretary General of the Kenya Union of Clinical Officers, as well as Brown Ashira, Secretary General of the Kenya Environmental Health and Public Health Practitioners Union. Let me come to you, Ashira, because it all sounds very good on paper, the implementation of SHIF itself. However, there have been major funding shortfalls to the Ministry of Health, even before the withdrawal of the finance bill, that had an implication on the rollout, even of the three funds within SHIF itself. What is the status now of these funds in light of the withdrawal of the finance bill and the expected budget cuts?
Most definitely, the fund is going to be affected and already has been affected. There are actually going to be budget cuts. There are actually going to be cuts in terms of the fund and all that things. But I think what we need to do is that before we do any policy, or rather before we come up with any act, there should also be an assurance that the ministry is supposed to set aside, because if at all we mean well for the primary health care or the universal health coverage in this country, there should be an affirmative action, or rather affirmatively set aside monies to be able to actualize these funds. And with the austerity measures that have been announced by His Excellency the President, I foresee to some extent a stall in some of these very good initiatives. Because ideally then, where do you be able now to finance this? Where do you get the monies now to finance these really good projects? But again, it's not even about the financing aspect. It's about what the amount, whichever the amount that is there, how is it being utilized? I heard a Kenyan, one of my good friends say sometimes back that NHIF used to have, they used to deduct monies. Where are we going to get, where is that money going to go? And I think Waziri was saying that it's going to be now to be shifted to SHIF. So I think we need to make sure that we ring-fence the monies that are actually been set aside for such a kind of act, because actually it doesn't make any sense, reasonably, to have a good act. And this country, we are fond of having very good papers, but we do not implement those papers because it's actually very weird. All right.
Yeah. I'd like us to focus a lot more outside of financing on the questions that Kenyans have, because there's a lot of confusion around this conversation. So let's begin, first of all, with the issue of Linda Mama. Where does this leave the Linda Mama scheme? Because it came in 2013 when President Uhuru Kenyatta launched the provision of free maternity. And so in 2016, the Ministry of Health transitioned these services to the NHIF. So where does this leave the issue of, antenatal, pregnant women at this point, Gibore?
Very well. Linda Mama is said to be a free service. What we say in the sector, and for those who are practitioners, we know very well there is no free services.
Yes.
The money used for Linda Mama are our own money, which we have been taxed. So it is government collecting our money and they're giving it back for our service. Now, is Linda Mama something that we need to appreciate? Very well. We appreciate it because it has given services to where it is. It had a lot of limitation, and it's good to point it out that it gives services to the expectant mother until to the point of delivery. Now, when there is complication, it takes only care of the mother, leaving out the child. So what this SHA is trying to say, we are expanding. So then when the child delivers, is also taken care of. You understand? Because we have seen mothers coming, when you deliver, your child has complication, you go back to do fundraising. And that should not be the case. Then that is why I have heard, and I clearly agree that we need to expand the services so then it can benefit the mother and the child. Is that something bad? No, good. Then that is where we go back, that we have good policies, implementation become a problem, and then we continue complaining. We had also another package similar to that, as you may allow, that we had the Edu Afia, where probably it was provided for the school-going children.
Right.
But you'll find the confusion which was there is that schools and some of the hospital have been used actually to steal this money. Because sometimes you'll walk to some of this facility far, some of the counties have gone places. You find that they admit school-going children from maybe Wednesday to the next Wednesday. That's a full week. And you'll find those children, they are stable. They do not even have any reason to be admitted, a number of them. So at the end of the day, they make claims. So then, that's to mean the school was partnering with some of the hospital to steal. But again, me as a parent, I might be having a cover that is covering up to my child. But again, the government has done what we call double coverage. Because then my child will be covered wherever they will be in school. So then the SHA is proposing to realign that so that you don't have an overlapping cover, which probably to some extent do not make sense, but in any case stealing from myself. Because this is the money the government is using to give me the services or my child is my money. So then for me I say it is good so that that can be realigned.
All right.
The still thing remain is the implementation. So when Kenyan talk about reinstate SHA, they need also to understand that it's a good statement, but again, we need to look at the pros and cons about the SHA, about the Linda Mama.
All right, Ashira, even as we discussed that, it's not just Linda Mama that is raising concerns. The Emergency Chronic and Critical Illness Fund is set to see dialysis, for example, fully catered for by SHIF, and also for oncology services, where SHIF will cover up to 400,000. But there has been concerns that then youth will be locked out of cancer screening, saying that young Kenyans will be forced to foot the cost of screening for 4 common types of cancer, despite making mandatory payments to SHIF. And this is, screening for colon cancer and prostate cancer. Is this a myth? Is it true? Give us the true picture here.
I think the real reason why that emergency critical and chronic illness fund is in the act is that it's supposed to take care of critical illnesses. It must be noted that most people sometimes during an NHIF, you could exhaust your cover and make sure that when you exhausted your cover, some people end up dying without even the finances, without even the power to be able to be treated because they have actually exhausted their cover. And this is what this fund is supposed to address. The issue about sidelining the young people from using from the cancer is neither here nor there. I think it is the ministry which is supposed to make guidelines. Any act that is done, act cannot be operationalized without guidelines.
Right.
When the guidelines are there, it's supposed to cover 100% all the people are supposed to benefit. And it's very clear, the contributor is, there's a 2.7% from the gross salary. So if, for example, the youth, for example, if I heard, was it talking about the means testing, because assuming the youth are not employed, there should be a mechanism to ensure that these young people do not miss out by way of ensuring that they benefit from the fund. Because it's very clear, the indicator is actually supposed to be very clear that there is a means testing instrument that's going to be used to be able to ensure that you are covered through the fund. Yes.
And so, of course, the confusion here there was that men between the age of 40 and 50 will have to pay for screening despite making the mandatory payments, and many say that this will pose a setback in the ongoing fight against cancer itself.
Yes. The issues of chronic emergency fund is already provided under an act. So we were only expanding on how this can be established and how it is supposed to be. So again, this is supposed to be funded through a government appropriation. So we expect that the government can put there enough money. And I know the budget had projected 75 billion. What was, I don't remember the exact figure that was allowed, or rather what is now given under the budget. That is something to discuss the next day. But again, what you're saying, the focus on UHC, universal health coverage, is to expand services without limitation, where you can be able to reduce those financial exposures where members are not able to be exposed to catastrophe. So then when you go and create boundaries again you are trying to put some limitation, you lose the sense of why then these services must be there. Are you trying to say that you have done a good survey, then you realize that no one gets such a condition, or rather is exposed to such a condition, then you limit there? No. Are you saying that those people are not contributing to the funds? No, they are contributing. So that limitation must be expunged and be allowed for all Kenyans who need the services whenever they need them to access those services. But one critical thing I need to point out, because then when we want to see the SHA giving meaning to Kenyan so that it can be appreciated, is when it gives me relief from the point where I was feeling like there was some exposure. Because in any case, by the way, it's true that NHF was not providing mechanism to allow facility to screen patient for chronic conditions.
Right.
So then that left people being exposed. But if again you go somewhere, you allow and then limit others, still you more of pronounce yourself to status quo. So we must be able to tell the government that that's not a good measure. And two, when we look at, because we were talking about the three funds, what they have provided under the tariffs, there is also a lot of limitation. For instance, currently the medication which you give under the first line for cancer currently is costing probably around 35 and above,
right.
35,000. Now they are limiting it. They are actually reducing that to around 15,000. They have not done an actual study to tell you that this is real what can happen. They have not said we have removed any taxation on the imported medicine for cancer. So how will it be, which miracle will work that then you can reduce from that 5,000 to around 15,000. Those are some of the questions that we are asking, and we feel that some of this rush must not be done, because then again we'll make a lot of mistakes that will continue lamenting in our years to come. Look at what we have provided under the same tariff for primary health care. You have introduced what we call per capita, and per capita you have estimated 900, which you estimate the total population around, and then you use 900 to calculate what money goes within that environment.
Okay. All right.
That's a very key point. And then you have limited that the only amount that a family can use, in that case, it's 1,800. So then when you look at, for instance, I come from Nyanza. If today a patient has malaria and they have access to a facility, you'll probably do the malaria test and you'll do full hemogram, and probably this patient is coughing, you might do maybe a chest x-ray. The cost is already higher than the 1,800 approximated. Okay. Where will the patient get the other money? We are still exposing the patient. In any case, the first bulletin of the reason why we are shifting is already actually defeated by the same virtue of the tariffs that we are providing. Okay. The tariff must speak to our own reason why we are shifting from NHF to SHA, that we need to prioritize primary health care.
Okay, and so we'll be coming back to a lot of that. Shira, so sticking with the primary health care, so under the primary health care fund, outpatient care services that are accessible at level 2, 3, and 4, yes. Primary health care referral facilities. When you take a look at the regulation, you know that they say the detail or the devil is in the regulations. Yes. It says that the primary health care fund will only be disbursed at the end of each quarter, which means that healthcare facilities will have to foot their initial bills, or that Kenyans will have to dip into their pockets. Is that a concern for you?
Very well, and that is very dangerous, because, you know, you are given a service based on what, you know, we don't apply to be sick at the end of the day. And it's high time, and I think what as George is saying is very true, that when I fall sick, for example, I'm supposed to go at the outpatient, then receive services. You know, this money I'm actually paying, and it's supposed to be done by the person, and also part of it is supposed to be appropriated by the government. So what is supposed to be done is that the government is supposed to provide at my need, because if at all you cannot be able to cover when I'm exposed, then what is the essence of the fund? Because if I cannot be able to utilize the fund when I so really need it, then it also defeats the logic why I need the fund in the first place. So I think it's high time that also such bottlenecks need to be addressed, so that when you're talking about the real funding of the healthcare system and the real person, that person enjoys what is supposed to be enjoyed. Because actually we pay insurance because we are actually protecting ourselves for the risk of unknown diseases. And so it's important such a bottlenecks need to be removed so that during operationalization of the Act, we see such a things being addressed so that our people benefit and the Kenyans benefit from the fund. Okay.
There's been a lot of concern about the financial protection that is offered by SHIF, including the means testing that you speak about, George. And part of the reason, I remember the uproar in the finance bill about KRA having access to people's data, and the government said part of that is because the government needs that data to conduct means testing, especially even for the social health insurance fund. Many are concerned about the quality of means testing and whether there will be people who are disenfranchised or left out.
There is something we call interoperability in the health sector, and of course it is in the information and technology, where probably, whether you like it or not by today, if I own up to around 5 gadgets, at any other time, all the gadgets are interlinked because there is other things that I share key. So at the end of the day, this data is already there, but they only want to have framework that they can be able to access. There is a time I attended one of the meetings. It was a very key meeting, and some people had come from the US. They wanted to sell data to Kenya. They only data for our people, and they tell you we have data for every Kenyan. So the services, all the time we use the kind of gadget we use, already our data are outside there. Now, is it wrong for government to have data? Data is key to inform in terms of the decision we need to make, so that then we can be able to appropriate and be able to utilize the resources, so that no one just appear in the hospital and pretend to be me and getting services on my behalf, or even someone claiming, because I know that even under NHF, there is a way they were supposed to use the digital framework where you use one finger, and then they used to do the one finger, and then you have an option of using the next to also inserting the second finger. So the people who used to do this, they give you the first finger and then they insert their own second finger, so that then they use their own finger to actually allow payment, or rather even services without your appearance. So these are some of the things that we need to kill. But I totally agree that there is no reason, and even if you say that you don't need, you have seen the kind of information we get from the Gen Zs. They can access information anyhow, whether you like it or not, because already information is interlinked by virtue of the system that the technology we have.
Right. And so clearly then issues of affordability and accessibility are largely tied around healthcare financing. And there's a report from Pathways Policy Institute that suggests that the 2.75% deductions from employed Kenyans and the non-employed will be paying the same tariff, although with a different figure, will essentially double or potentially double the total contributions from 60 billion collected by NHIF to about 125 billion. And it's a huge increment. What are your thoughts on, and we've talked about a lot about the management of these funds, but how much more can be done with these funds? Because we've had Kenyans question, even in the light of the anti-government protest, where Kenyans contributed to a kitty that was just about 30 million shillings. And so many are asking, guys, if we contributed these 30 million shillings in a kitty and managed to sort out hospital bills of all those who were injured during the protest, imagine how much more then SHIF can do with 125 billion shillings. How much more can be done?
Very, very true, and I think you're right. But the problem has always been, it boils down to the management of the fund, because whether we like it or not, I can even have 200 billion, and someone has 60 billion. You can, if you do the math, the 60 billion person, the way he utilizes his 60, and the way I utilize my 200 billion, there are people opulent, and others, the priority is what we're actually talking about here. If the SHA, the Social Health Authority Fund, will be able and be good enough to utilize the fund, now that it has doubled, it will be better so that at least the services to Kenyans actually realized. And I think we also need to change. The primary health care fund, Madam Ngele, is that we also need to speak about the prevention. The primary health care fund is silent on prevention, because It is actually, if you look at what, if you advance anything, health case, anything go by, right from the Alma Ata in 1978, the way it was envisaged to protect us from diseases. And it's high time, this country, we also change the conversation from the patient-centered now to the community-centered, because sometimes we don't get it right, because we have very good things like the primary health care fund is supposed to actually to purchase preventive and promotive healthcare services. But we realize at the end of the day, we keep now boiling down to diseases. I wish one day this country can also start talking about how do we now prevent even these cancers? How do you now even prevent these cardiovascular diseases, the disease of the heart and all those respiratory infections that are actually as a result of air pollution, so that we also bring down the cost of non-communicable diseases by 2030. We should not be like we are projecting diseases all along. And the Ministry of Health is not a Ministry of Diseases, it's actually Ministry of Health. We are supposed to be seeing people actually very healthy, because some of these monies that we actually spend and appropriate in terms of healthcare can actually go to roads and can actually go do other things as we actually cut down the rising burden of diseases. So, and that one can only be realized, and I think the President got it right when we brought in around 100,000 health community workers, but now the problem is down now. The public health officers and technicians who actually at the ground, who actually supposed to supervise these CHWs, how are we actually supposed to be able to support them and support their activities?
All right.
That's what we actually need
and it's an important point that you bring in. And Gibode, what are your thoughts on that? Because prevention is essentially why the government contracted community health promoters on the ground to ensure that Kenyans are not going to hospital when things are really bad, which is a Kenyan, it's a Kenyan trait, it's a bad Kenyan trait. Where are we with regard to prevention? And with regard, in light of budget cuts, then should we channel our priority, all our focus there in UHC?
We have a lot of studies, and studies have pointed that every shilling used in primary health care, that's preventive promotive services, saves 9 shillings that will have been used in curative services. Why? It is very costly for management, or rather for treatment to take place at the curative services. That's high-level facility than when you do it at the lower facility. It was very key for the government to come up with the primary, the community health promoters or promoters who actually link the health professional with the community. And in any case, establishing under the primary health care that now what we call the household become the first primary unit of service delivery. So then that's why they will move around with some gadget, they test and actually advise you or link you to the next facility where you need. For instance, if today I was a health promoter and I move around and I get that there was a child who did not go to school, they are sleeping. What is wrong with the child? She's sick. And why they have not gone? Probably it is because the mother was sick also, or even they could not have time to bring the child. So you aid that child to go to the hospital. That is the kind of services we need to see. Has it worked? I think we are still at status quo because one, as we do, because these health promoters are sensitizing community to seek services. Every time this community are sensitized to seek services in our public facility, we have not increased the health professionals, so that then in the nearest facility, we have enough health professional to see the patient. And secondly, is that still our laboratories are not functioning in those primary facilities. That's level 2, level 3. Again, there is not drugs. So whenever they appear, actually they look at it like a PR. Why should you tell me to go to the hospital, which I might not get services? Let me give a good example, Michelle. Where I come from, it is probably a mother has 3 children, 2 of them going to school, and has 1 that remains with the home, and they have to take care of the shamba and also the cattle. So what they do, they go when the child comes from school, she's sick, and the mother is choosing to prepare lunch and also take care of the other child, and you are supposed to be taken to the hospital. So they choose to postpone that until tomorrow. But again, when now this healthcare promoter comes around and they find that there's a child who yesterday did not came back, they were sick, and the mother is still occupied with the other primary things that they are supposed to be doing. So what happened is that you refer this patient, but to where? either to the level 4 or level 5. Because level 3, I have seen the Auditor General report is that close to over 75% of our primary, that's level 2, level 3, do not have the requisite trained professional to function optimally. And they do not have the support that is required. Now, with this SHA that we have projected that it is going to operationalize the primary health facilities, the level 2 and the level 3, to ensure that then it can take the reason for establishing the primary care funds and also the primary care services can be established and be operationalized. It is actually killed by virtue of not estimating or rather giving the fund that is required. So up to date, there is no money to fully operationalize those services. And to this gives us a fear that we are still actually running on the status quo as much as we continue preaching. Kenyan will appreciate at any time we take action and ensure that they are appreciating the services more than preaching to them, telling them what we are going to do, and it doesn't come through. Let us ensure that it's functioning. We appreciate the 100,000 community health promoters, but do you know there was an agreement that county was to pay them 2,500 and also the national government to pay 2,500. Some of the county did not honor that agreement, and the national government went on to do the same. What come of that is that the county now are claiming that the national government is taking over their services. But we must say that there is a confusion in the health sector in terms of governance, because then the county government believed that health was devolved. How was health devolved, and yet a key function like financing is still coming from the national government? That's a valid point. Allow me finish kindly, if at all. Out of time. To make sense. So that then we must be able to applaud, even during this time that the president has established a team to do an audit in the health sector. We look, since we went to devolution, what are the things that have not worked? But again, we must say that that team, for us, we feel, and I need to register my discontentment, it is not well balanced to ensure that it has some objectivity that we expected. Okay, so then there's a lot more to discuss in the health sector. Ashira, very, very briefly as we wind up, what are your expectations then in terms of communication and implementation that you expect to see before the official rollout of SHIF on the 1st of October?
I expect the national government to come on ground, engage us, engage the stakeholders. We need to roll out. Before the rollout, people need to be sensitized. We are the stakeholders who are supposed to go on the ground and make sure that we let, you know, there's a lot of disinformation at the ground, especially like what you've mentioned about the youth and what have you. There's a lot of disinformation. We need to come out clearly and tell Kenyans that the Act talks about this, the regulation says like this. So I expect a massive rollout, massive health education, so that the members, the Kenyans understand what is supposed to be to be done at the SHIF. And last but not least, I want also to employ to the government that consider strategies like prevention. Environmental health sanitation has been proved to be one of the most effective, even during COVID-19 pandemic. Even washing hands and putting on masks proved a very, very resourceful intervention in terms of disease prevention. So focus on preventive care is key in implementing UHC. Many thanks, gentlemen, for speaking to us. That is Brown Ashira. He is the Secretary General of the Kenya Environmental Health and Public Health Practitioners Union, as well as George Gibore, who is Secretary General of the Kenya Union of Clinical Officers, discussing that shift from NHIF to SHIF. Many thanks for watching this morning. My name is Michelle Ngele Odhiambo. Do enjoy the rest of your viewing.